Now, how do I plan a surgery in this eye? He's an 80-year-old gentleman who has brown cataract, which is evidently very hard. He has got mild phacoemulsification, non-dilating pupil, pseudoexfoliation, and the cornea doesn't look to be great. So, multiple challenges to deal with. Number one would be, how do we deal with the zonular laxity? Number two is, how do we deal with the density of the nucleus? When you're trying to divide this nucleus, any stressful maneuver is going to impact the capsular bag and the posterior capsule, especially in a bag which is not so healthy. Add to it, he has a very shallow antechamber depth, and I need to have my multiple plans ready. So I got 5 major concerns to deal with. Apart from the small pupil, which can be dealt with an expansion device, my major concerns are the corneal health doesn't look to be great. There's no space to work in. The chamber is very shallow. We have got a very dense and a bulky hard cataract. The zonules are weak, and there's always a risk of fluid misdirection. So these are the things which are running in my head, and I have listed it out. So to deal with the pupil, I'm going to use BX expansion device to begin with. I have kept capsule hooks as well ready. In the event of the capsule being extremely lax, maybe I would use these capsule hooks as a bag supporting device as well as a pupil dilating device. That is an option which I kept it ready. Apart from this cohesive OVD and dispersive OVD, a capsule tension ring to support this bag. So I've also kept a multi-piece lens ready, so that my plan is to use the IOL trap technique, wherein the IOL will be supporting the bag rather than the other way around. And of course, if things just don't go the way we planned, I have kept the iris claw lens as well ready. So with this plan in mind, I'm going to plan a scleral incision, because as we all know, if I need to use an iris claw lens, I again have to create a scleral tunnel. So I plan to do a phaco through the scleral tunnel incision itself. Conjunctival peritomy is made. The trick here is not to make a large scleral tunnel. I'm making just a 2.2 mm scleral tunnel. The 2 side ports are created. I'm using intracameral dilating agent, that is phenocaine, to try and see whether the pupil dilates a little bit better. The iris seems to be very floppy, as I'm finding it difficult to introduce my cannula through it to inject the dye. I can see there is some iris which is traumatized, so I have an additional situation to deal with. Now, because the pupil won't dilate well, the subpupil anterocapsule would not be stained much. And I'm skeptical in pushing the dye behind the pupil, because sometimes it might traverse across the lax zonules into the Berger space, and then I may lose the red glow, and at the same time I also have a positive pressure because of the fluid misdirection. So I'm a little bit skeptical of putting it there. So after entering into the eye, now is the time to place the B-hex ring. The visibility actually was not so great. The cornea was not very clear, and the iris and the BX ring are almost same color, so it's very difficult to see. Actually, in the video footage which you're seeing, we have added a little bit of a contrast and color, and the differentiation, the clarity is much more in the video footage than actually what I was seeing there. So just to show you a comparison before color grading how it was looking. So when I'm negotiating the notches of the BX device onto the iris, you can clearly see that the underlying lens is wobbly. The lens is almost moving around the moment we touch the anterolens capsule with the forceps. So this is a very clear sign that the zonular health is quite poor. Nevertheless, I could manage to place the B-hex ring in position. We have a pupil which is about 5.5 mm diameter, and obviously a larger part of the capsule is exposed. So I'm just trying to restain the anterocapsule with the trypan blue. I'm hoping that it can help me to see well. But as we all know, a capsule which is already tasted an OVD, it's unlikely to take up the stain. Nevertheless, something is better than nothing. I'm not attempting to puncture the capsule with the forceps. I expect the capsule will be so lax that I cannot perforate with the tip of the capsule or forceps. So I'm going in with my sharp 26G needle, and as I'm puncturing it, we can see there are multiple star folds appearing at it, suggesting the zonular laxity. And as I'm trying to raise a flap, the bag is moving along with my needle. In such eyes with zonular weakness, I always prefer forceps to a needle because you get enough traction with the forceps to tear the capsule. We don't have the counterforce by the zonules because of their laxity. And that's the reason why we need to use an additional force while tearing. And so I think it's one of the mandatory situations where forceps is to be preferred compared to needle in these eyes with extreme zonular laxity. The forceps ensures that we don't compromise the already stretched zonules. Rexis sizing is extremely critical here. To have an optic capture, I would prefer to have a Rexis which is around 4.5 millimeter. But because this is a dense nucleus, the nucleus division is going to take up a lot of effort, and a bigger Rexis is going to help me. The most important step in eyes with generalized laxity is to get a good height to dissection, because this is one step. If we can achieve it right, further nucleus rotation and maneuvering is not going to worsen the already existing zonular weakness. The first attempt of hydrodissection, when I decompress the bag and try to move the nucleus, we can see the entire bag is moving around. So I decompress the bag, again place the cannula in the opposite quadrant, inject very little amount of fluid again, and again go back and try to decompress the bag and nudge the nucleus around, hoping that the corticocapsular adhesions are released. Still we can see that the bag does move along with the nucleus, and this doesn't look to be safe. So at this stage I cannot proceed with forceful nucleus rotation, or can I directly go and start phacoemulsification, because this amount of laxity is going to worsen when we try to maneuver the nucleus forcefully. So this is the right time to stabilize the bag. One can always use capsular hooks, but I would prefer to use a capsule tension ring now itself, which can provide 360 degrees support to the bag. And hopefully I may not require to create those 4 paracentesis incision to introduce those capsule hooks. So one trick for an easy insertion of CTR in a bag with a bulky nucleus is to create some space. I'm going to use sodium hyaluronate under the area where I plan to introduce my ring. I'm just injecting under the anticapsule. This creates space, and then I'm going to thread in the CTR very gently. So once the CTR is threaded into the bag, I get a sense of security that the bag is now having some sort of an artificial zonular support, so it looks to be much more stable, and I can now rotate the nucleus and confirm that the rotation is easy and not stressful on the capsular bag. So with the CTR in the bag and providing the support, I go in with the chopper and press the nucleus down a little bit and then try to rotate it. With the support of the CTR, the bag is held stable and the nucleus rotation can be done without any stress on the bag, and the bag doesn't seem to be moving along with the nucleus. So at least one part is taken care of. Now is a challenge to deal with the nucleus. Now this is a grade 5 nucleus, and during nucleus division it is going to be enormously stressful, both the bag and the posterior capsule. So consciously I've decided to adopt the classical 4-quadrant technique in this nucleus. The reason is, by making the central groove, we are going to break the posterior plate much more easily and requiring lesser amount of lateral separation maneuvers. So let's see how things turn out. Before starting to sculpt, I'm in the epinucleus mode just to clear off some of the epinucleus in the loose cortex, which is non-existent. This will ensure that the flow is present in the phaco tip, and this is one way we can prevent ourselves from being surprised by, having a wound burn, especially if the tip is clogged with OVD. These are the settings which I'm using for sculpting. Please note the presence of extreme high power. I'm using a balance tip on a Centurion machine, 90% power. These are the fluidics parameter. You can see the low vacuum and the flow rate. The nucleus is stabilized with my second instrument as the sculpting is begun. My aim is to go at least 80 to 90% depth. I'm going to create a large single trench now, then rotate the nucleus and then create another trench. So basically we want to divide them into 4 quadrants. Please take a note at the phaco power reading. So I'm using 100% of the energy, that is every time I press the foot pedal it's going to go to 90%. The idea is we want to use the cutting energy of the ultrasound rather than mechanically pushing or shoving at it. While rotating the nucleus, I'm using both the instruments, the chopper as well as the phaco tip. So this bimanual rotation of the nucleus is extremely helpful in eyes with lag zonules. So we don't get the counter traction of the zonules of the normal eyes in these pseudoexfoliation eyes. So it's always a great idea to use these two instruments to rotate the nucleus, which is much more efficient and less traumatic to the zonules. So I'm very mindful that I'm not showing at the nucleus. I'm just using the cutting efficiency of the ultrasound power to just melt down the nucleus in front of it. So once we have reached a sufficient depth, now is the time to perform lateral separation. I'm able to clearly see that the posterior plate is really thinned out. I think this amount of depth is good enough for me to proceed with lateral separation. The phaco tip and the chopper go right into the crater which I've created, and then I'm doing this lateral separation maneuvers. The first crack is got. The nucleus is gently rotated. The chopper and the phaco tip are placed as deep as possible in the crater, and then the lateral separation is done. So again we can see the crack is ensured, the nucleus is rotated again, and the third crack is initiated. So now we have divided the nucleus into smaller fragments, but these fragments also are quite big. And it is going to take some effort and to divide them again before emulsifying them, because there's very little space in the antechamber and we would be working very close to the cornea. So that's the reason why it's mandatory that at least I attempt to divide it into still smaller pieces. So replenishing some OVD into the antechamber, dispersive OVD goes in first, followed by HPMC. So I catch hold of this fragment, I pull it out of the bag, and I'm emulsifying this quadrant. This part of the footage is slightly sped up, but I want to remind you the principle. I want to work as posteriorly as possible. I am working probably at the level of the pupillary margin or just below it. So I don't want to come anywhere near the endothelium. The lens matter which is there under the left side port is the soft epinucleus. Once the harder nucleus is emulsified, the soft part is taken care of. So protecting the corneal endothelium is an important goal when managing these cases, and the plane of emulsification becomes extremely critical with that aspect. OVD is replenished into the eye, the nucleus is rotated, and this fragment looks to be very huge. I try to separate the fragments, it's not separating. I think in the initial cracking of the 4 quadrants, I didn't do the 4th crack. I just overlooked at that time, and now we have. The crack is not complete in between these 2 pieces. So I go in with my phaco tip, bury the nucleus, pull the nucleus out and trying to divide it using a horizontal chop technique. So I just want to divide them into smaller fragments as they're getting emulsified. As I'm phacoing the adjoined 2 pieces, they flip. I've got access to the bottom of the posterior plate where they're attached, and just phacoing this base part separates the 2, and then they're eventually emulsified. It's important for us to be very conscious that are we in control of the surgery as it is being done now. So as long as we are in control, it's fine. So we need to keep asking these questions as things are being done. Again, OVD is put in, the nucleus is rotated, and the last chunk of the hard nucleus is being taken care of. Please note the plane of emulsification. I am attempting to be at or below the pupillary plane. My second instrument, which is a Sinskey hook, is above the nuclear fragment, and the nuclear fragment is dancing around the tip as it is getting emulsified. So being very slow and judicious with your phaco energy is going to help us to have good control when we're emulsifying this fragment. I can emulsify it in a jiffy just by increasing a little bit of a power through my foot pedal, but it's going to induce a lot of chatter and turbulence, and I believe it's going to be traumatic to the endothelium. Time to aspirate the cortex. Now, once the retroillumination mode is turned down, we can see that there are a lot of debris in the vitreous. This is not surprising, as in these eyes with generalized zonular weakness, in eyes with pseudoexfoliation, we always see that there is some amount of transfer of material across the zonular barrier into the Berger space, and these particles or debris behind the posterior capsule are representative of that fact. And these are the cases where intraoperative aqueous misdirection is a relatively common feature. And this is one clear sign of that. And during cortex aspiration, the chances of this pressure build up and the posterior capsule tenting up is much more higher, and we need to be cautious of not breaking the posterior capsule, which is very vulnerable at this stage. So even with the CTR in the bag, we can see that the cortex aspiration is not so difficult. Of course, it takes a little bit of time. We need to be patient. Just engage the cortex. I don't aspirate it, just engage it and try to maneuver the strip of cortex from its attachment and pull it around. So by doing this, we can negotiate the cortex even in a bag which is extremely loose and has an in situ CTR. Again, care has to be taken not to touch the posterior capsule, because we can also use the irrigation handpiece to retract the iris to see better, and then we can engage the cortex and then slowly strip it across. But we need to be mindful that the fluid which is coming through this irrigation port has access to the burger space, and this is the common reason why we can have buildup of pressure. And at this moment, we can see that the cannula is in fact momentarily caught the posterior capsule. We can see the spider web appearance and reflux button is pressed and it is released. So these are expected things to happen. We need to be ready to manage them. So again, I'm telling myself not to overdo things. If there is one streak of cortex left, it is fine. It's all right. That's not I'm telling myself. Time to implant the lens as was planned. We're going in for the IOL trap technique. Space is created in between the iris and the anterocapsule by injecting cohesive OVD. This makes us easier for us to negotiate the haptic over the anterocapsule. The distal haptic goes in first, followed by the proximal haptic. Both the haptics are dialed and they're sitting above the anterocapsule. Now, before achieving optic capture, I need to remove the OVD which is gone behind the lens and in the bag. But first, the BX device has to come out. So it is disengaged. Then it is pulled out. Now, the visibility is not so great and I'm finding it difficult to identify the BX ring which is merged with the iris. So it took a while for me to identify the right spot to catch it and then disengage and then pull it out. The iris is very floppy and is trying to come out through the main incision. Time to remove the OVD both in front and behind the lens. Now is the time to achieve optic capture. The irrigation is in my left hand and the optic of the lens is gently pushed back so that it goes behind the rhexis margin, and this ensures an optic capture. Since the pupil is come down, I'm just retracting the iris just to make sure that I'm seeing this ovalization of the rhexis. This confirms that the optic is truly behind the rhexis margin and the haptics are in the sulcus. So once the optic capture is confirmed, time to close. Now, since there is a little bit of a floppiness of the iris and is trying to come out through the main incision, I'm going to use a 10-0 nylon suture to suture this scleral tunnel incision, followed by conjunctival closure. It was a tough and a lengthy case, but thankfully the implementation of all the plans which we had thought of went off well. And it's not surprising that when we are really thoughtful and plan your cases very well, most of the times you'll not have any intraoperative surprise. So that's the benefit of having a meticulous planning. So these are the first day post-op pictures. The patient is doing fine, and I hope that this IOL trap technique, wherein the lens is literally holding the bag, ensures long-term stability and centration of the lens. That was it. Thank you for watching and hope you found this helpful.